Hey everybody, we are going to go ahead and get started. Rob, do you have the? Okay, awesome. Hopefully most of you know me by now, but in case there's a new face that I haven't had a chance to meet, my name is Amy Hartle. I am the Vice President of the Board of Directors for the Breast Cancer Network of Western New York. We are very appreciative that you are here tonight. I know it can be tough to have an evening event now that the time has changed and we are back to a little bit, starting to get dark earlier in the evening, but we're really glad you're here. And anyone joining us on Zoom, we are glad we see you, or we know you're there, and we're glad you're joining us as well. You're just missing out on pizza, but other than that, the comforts of your own home, I get it. So I'm very excited about tonight's talk. It's always very well received when we have one of our local doctors here to talk about their craft, their skill, and how that serves our community. So we're gonna get to Dr. Tambar in a minute, but first I'd like to welcome Melissa Wanzer. She's gonna do her formal introduction herself to tell you about an upcoming event next week that is going to be held here as well. So Melissa, sure.
Hi, everyone. Thank you for having us tonight. I'm actually also from Great Lakes Cancer Care Collaborative. I am the Oncology Survivorship Program and Outcomes Manager. I've been in this role for about 4 months. In my former life, for 26 years, more than 26 years, I was a college professor at Canisius and taught interpersonal family research methods and health communication. I loved teaching. About 6 years ago, I was diagnosed with breast cancer and I shifted my research. I started focusing on survivorship. I started focusing on using services to stay healthy and well. I'm sure many of you know of that feeling of you're done with treatment and now what, right? And that gap between active treatment and the rest of your life. And so I was really interested personally, right, both personally and professionally, in kind of filling that gap and looking at how we can all stay healthy and happy, right, for the rest of our lives, right? So I am really excited to be in this new position. And one of the things that we're doing is offering monthly seminars, right, through Great Lakes Cancer Care Collaborative. It takes me like 5 minutes to say that name. But we're offering monthly seminars, so we have one on nutrition, and the next one coming up is on lymphedema. And I'm really happy and excited to have this seminar because I actually went to Beatrix, and I found her by accident, which I know many of you probably have these experiences of, someone knows someone who knows someone who knows someone and says you should probably go see this person. And so when I took this job, one of the first seminars I thought that we should have is lymphedema. And she's a physical therapist, a certified lymphedema specialist, but she also works with post-surgery, getting your mobility back, which I know is important to me. So that seminar is going to be next Tuesday, and I have flyers, which I'll pass around to remind everybody. And then after that, we'll be having one each month. And the next one that we're going to have in December, I'll send out information about that if you want to give me your email. That's actually going to be Coffee, Tea, Cancer, and me looking at what is out there for you in survivorship free, right? What kind of services and resources exist. So like we have a free emotional support group, right? So that's something that already exists. And I think a lot of times people just aren't aware that these services and resources are out there. And I know that this probably isn't relevant for us, but we have a pre-surgery education class, right? That most of the surgeons, the breast surgeons, send their patients to because it's really helpful in getting you ready for that surgery, whether it's a lumpectomy or a mastectomy. So there are a lot of things out there that people just don't know about. And that's one of the things we're going to focus on. But we're also going to talk in December about what else do people need, right? Like scan anxiety. You heard that term, right? That's a big issue. People get really stressed before they get scanned. They have to go for their yearly or monthly or, 6-month mammograms or CAT scans or whatever it is. So those are some of the things we have planned. And I'm really excited to work with the Breast Cancer Network. I've been working kind of behind the scenes on social media. My students have worked, they were doing some social media things last year. So I'm excited to collaborate. Thanks for having us.
Are you the talks at different locations?
Yes, they are going to be, we're going to try to, for accessibility, to try to rotate them around. So next, Tuesday is here, but the next one will be at Western New York, Cancer Care of Western New York on Harlem. So, one of the things we're going to try to do is reach a very diverse population, to get as many people to these programs as we can. So we'll have some at Spindrift, we'll have one there in different locations. So that's a great question.
Will they be virtually available?
Yes, we will try to do that. Absolutely. Because that's another thing. They're virtually available. Yep. Yeah. So thanks. All right. I'm going to pass the.
Okay. Well, thank you. And this was actually just a quick add-on to what Melissa shared. Sometimes I'm very excited about this lymphedema class coming up next week, or this talk. As some of you know, I'm an oncology massage and lymphatic drainage therapist. So I work with people like B who will be speaking to help support clients. And we were just talking about the fact that sometimes people think that if they don't have a lymphedema diagnosis, they've never experienced lymphedema yet or at all, that they don't need to be aware of it. They don't think about it. It doesn't pertain to them. And I think it's really important to know that, unfortunately, most of us who've gone through any kind of breast cancer treatment have some level of risk of the possibility of developing lymphedema. And so understanding why and what that risk is really critical to helping to potentially never having to deal with an actual diagnosis. And so this talk, seminar next week is going to speak to that as well. So hopefully very few of you, if any of you, are actually dealing with lymphedema, but that doesn't mean that you shouldn't check out this event, because it pertains to all of us at this point, regardless of actual diagnosis. Thank you, Melissa. All right, so tonight, our featured speaker, I'm very proud to welcome Dr. Stuti Tambar. She obtained her undergraduate and Doctor of Medicine degrees from the University of Buffalo, in addition to completing her residency in the general surgery training program. Dr. Tambar continued her training with a specialization in treating malignant and benign breast disease from Georgetown University in Washington, D.C. Following her specialized training, Dr. Tambar served as a breast surgical oncologist in California before returning home to Western New York to give back to the community that helped her become who she is today. Dr. Tambar's clinical interest focuses on screening and identifying high-risk patients that will benefit from surveillance. When she is not working, she most enjoys spending time with her husband and 3 children, cooking and running. And I'm going to let Dr. Tambar talk to us about what her plan is for tonight. And I know we're going to have some good Q&A time. So if you would try to save your questions, and then we'll take it from there.
Thank you so much for that introduction. Thank you for having me today. So I actually have a lot of time for Q&A. So if you want to put some in the middle of it, that's totally fine. Otherwise, it'll be a very short talk. So I grew back in India. I was there for about 21 years before I got married and moved to Buffalo. And then when I came to Buffalo, I didn't have a whole lot to do. So I went back to school and went to undergrad, went to medical school, stayed here for residency, had my kids in residency, went to DC for my fellowship, and then moved to California for a few years. Thought we'll just live and die there, but that did not happen. And we decided to come back because it was just a little too hot for us. So I guess we just love Buffalo. So we're here, and very, very excited to be here today. Thank you for having me. As I said, so my interest in breast surgery was actually something I did not intend. When I went to medical school, I thought I want to be either gynecologist or pediatrician. But as I went to medical school first couple of years, I thought maybe I want to do GYN more, do more women's medicine. But when I did my GYN rotation as a 3rd-year student, I didn't really enjoy it as much as I thought I would, and I kind of was lost at that point. So I did my surgery rotation, loved it, loved every minute of it. I mean, everybody told me to not go into surgery, like, that's a man's job. It's, why would you put yourself through this torture? Just go to pediatrician or ER or something, but I just couldn't like anything else. So I went into surgery, but I felt like I'm kind of losing that initial focus that I wanted to do in women's medicine. So, but you know, I was just gonna go with it and see what happens. And then I did my breast surgery rotation and I just fell in love with it again because it was kind of brought me back into women's medicine, kind of advocating for women's health and doing more in terms of what I would like to do, which is surgery, but also helping to do more for women. So it was just a like automatic fit, which I didn't even consider going into medical school. So I don't fortunately have any family history of breast cancer, but I have in medical school and in residency, I just seen so many patients with breast cancer who were coming for hernia repairs, who were coming for other problems, but they had this whole story, whole life they lived with breast cancer, that this hernia was just this little thing that they have to get fixed. But I've been through breast cancer, so now I can do anything. So it was very encouraging to see how far breast cancer has come from when it was initially started to get treated with the Halsted mastectomy. So I don't know if anybody knows who Halsted is or what that mastectomy was, but Halsted was a surgeon about 100 years ago, and he started doing mastectomy for women with just any breast mass. So, and they didn't know how to find the cancer. So they would just take out the breast, take out the muscle behind it, take the skin, leave a giant gaping hole and let the women fill it up. They will also remove every single lymph node in the axilla. So those women were 100% getting lymphedema. So your service would have been very needed a century ago. But we have come far away from that Halsted mastectomy, as we call them. It took about 80 years for men to get away from Halsted mastectomy. For 80 years, we kept doing that kind of mastectomy for women without even a diagnosis of cancer. So about 80 years later is when we started accepting a mastectomy as a simple mastectomy, which is save the muscle. We were still removing the skin, we were still removing the breast, we were still removing the lymph nodes, but we left the muscle alone. And then we started de-escalating the surgery more and more to now where we're doing nipple-sparing mastectomies, which I did 2 weeks ago. So it's becoming more and more common because we're realizing that Halsted mastectomy was just an excessive over treatment of women cancer without even trying to understand it or identify what women needed. Because as you can imagine, living in a paternalistic society, women's disease was not that given that much weight. But now that we are hopefully turning over, we are looking more and more to de-escalate, kind of trying to give equity treatment to our male and female patients. So my talk today kind of focuses more on is this the laser? I don't want to turn it off.
I don't know. Rob, do you know how to operate the?
Okay, so most of it is screening and genetic testing and some chemo prevention. I was going to add more of this, but I thought I'll talk more about what's kind of latest and greatest in breast surgery. So I'm actually going to not talk more about, I'll talk about the first three, and then we'll talk about what the current trends, new up and coming in breast cancer is. And then, you know, as I said, feel free to stop me and ask any question that you may have. Otherwise, it'll be a very short talk. So for average risk women, and these are women who have no breast cancer risk. These are women who have no family history. They have no high risk factor whatsoever, never had a suspicious biopsy done that showed anything of concern. These are the women who are recommended to start the mammogram at the age of 40 and then continue mammogram every year until their life expectancy is greater than 10 years. So I see a lot of patients, I actually just saw a patient, she's 92 with a new breast cancer today. And she was told to stop getting mammograms at the age of 65 because why do you need that after 65? So there's no such data, there's no age cutoff. I have a lot of women who ask me, when should I stop? I'm like, when somebody tells you you're not gonna be alive in 10 years, you can stop. Otherwise, you need to continue getting the mammograms every single year. And we have been adding ultrasounds lately for women who are identified to have a little denser breast. MRIs are reserved more for a higher risk patient, which I'm going to talk in just a minute. So these are the high risk patients. So how do we identify these patients who are high risk? And as you can see, these may be fluid in the sense of family history changes. You know, your aunt may suddenly be diagnosed with a breast cancer, and that affects women's risk. So one of the reasons that women can be high risk is gene mutation. So BRCA is the most common, most popular gene mutation, I like to put it, like Angela Jolie had it. So, she got a double mastectomy before she had cancer. And I can make these slides available for anybody who wants it. This is nothing, I'm not afraid to share it. So these are the women who have BRCA mutation, but there are about 36 genes that we test for. So any woman who's identified to have high risk and meets the genetic testing criteria, we do one blood draw with a tube and it tests for 36 gene mutations. And BRCA1 and 2, as I said, is just more popular, more women know about it, and they definitely want to make sure they don't have that gene. Because that gene puts you at a risk of about 80% to have breast cancer, as opposed to the other genes, which ranges from 20 to 60%. These women need MRI starting at the age of 25, and they can start mammogram at the age of 30. And this is the only, pretty much the only mutation I would start that with. And thankfully, I don't see a lot of patients with BRCA mutation. I see patients with some other kind of mutation or no mutation at all, thankfully. Those women I would start an MRI at the age of 35. So there's a high risk model that we use, and this is a very popular model. There used to be, I don't know if anybody heard about Gale model. There's modified Gale model, and now we use this thyrocusic, or we just call it TC score. So this is a TC score that helps us determine what is a woman's lifetime risk of having a breast cancer. So an average woman with zero risk, zero family history, just going for routine screening, their risk is about 12%, 12 to 13%. Anything over 20 is considered a high risk. So these are the women that we have in the office, and we have them fill out a short form, and they give us the information that tells us exactly what their risk of breast cancer is over the lifetime. And that takes into account, when did they start having their periods? How long did they have their periods? When was their first childbirth? How dense are their breasts? What kind of family history do they have? Did they ever smoke? Did they ever take any hormone replacement treatments? So there's lots of information that goes into this risk factor that tells us exactly what the patient risk is of having cancer over their lifetime. And if it's over 20%, we tend to give them a high risk. We put them in high risk monitoring program, where in addition to their annual mammograms, they also get annual MRIs. So this is no cancer. Based on their risk model, we actually start them on high risk surveillance, as we call it, or high risk monitoring. It's the same thing. And these are the women who get genetic counseling. We try to see if they have, if they need genetic testing criteria in that case. And then we start screening them for breast cancer 10 years before the youngest relative. You'd be surprised, women are getting younger and younger when they get cancer. My youngest patient right now is 27. So and she's planning on having children next year. So if she has a girl, I'm going to have to start screening her at the age of 17. So we do start screening women at the age of about 10 years prior to the youngest relative. And their mammo still starts at the age of 30. But the MRI, I tend to start at 35, unless they have a family history that is younger than 45. So it's always younger than 10 years. So if it's younger than 10 years, and it's, again, women tend to be, getting diagnosis. Still, the most common breast cancer is postmenopausal. We're not seeing that many young patients, but they are getting younger. So women get mammogram and MRI after they are diagnosed with high-risk breast cancer. And this is that modified Gale model I was talking about. It takes in account less family history and more personal factors. So I prefer the thyrocusic model just because it gets a lot more information. And then there's a personal history of breast cancer. So there are some criteria that the NCCN guidelines has made. So NCCN is a national cancer care network. They come up, these are the panels of experts, and they come up with guidelines. They come up with guidelines for treatment of breast cancer, of all cancers, not just breast. So they have NCCN for breast, they have NCCN for colon and rectum and prostate and lung and everything else. So they come up with guidelines for how to treat women or people with any kind of cancer. They come up with guidelines of who to test for genetic testing. And this is a moving target, honestly. I made this slide about 8 months ago, and it's already changed. So it used to be that women at the age of 40 to 46 to 50 can have genetic testing if they have multiple primary cancers or more than one blood relative. That one is already 2 now. So they're making it stricter and stricter almost to get genetic testing. But these are still the criteria they have to come up with every year to review and see which women meet the criteria for genetic testing. And as I said, genetic testing is a blood draw, 1, 2, and it's not just for breast, it's for colon cancer because they are gene associated with colon cancer. So if you were to show up to a colorectal surgeon or a colorectal medical oncologist and you say, hey, I got like 3 relatives with colon cancer. So there's a whole gene panel, which includes 47 genes for colon cancer. So these tests are getting more and more sophisticated and more personalized based on your family history. They're not just one size fits all, it's based on what you need. So these are all up and coming, and these are, as I said, moving targets. So we have to keep an eye on it whenever we're trying to do genetic testing and recommend it for patients. So a chemo prevention it's not chemo. I know everybody hears chemo and they think we're going to give you chemotherapy. Chemo prevention is just giving a medication to prevent breast cancer from forming. And these are women who have higher risk of having breast cancer. So there's actually women who are diagnosed with atypical hyperplasia. I'm sure you heard about atypical ductal hyperplasia, atypical lobular hyperplasia. They're not cancer. They don't turn into cancer. There's no cancer around them usually after surgery. Then women don't have cancer. But these women are at 40% or more of having breast cancer in their lifetime. So whenever we see these kind of results in a biopsy, we tend to give these women a medication to reduce the risk of future cancer. It's just tamoxifen or anastrozole based on your age. But those medications have shown to reduce the risk of these women with breast cancer. So premenopausal women can opt for tamoxifen, and postmenopausal women can opt for tamoxifen and other agents. But these are women who are identified to have high risk based on just their biopsy results. So these are, again, it's hard for sometimes for us to convince women to take a pill because they don't have cancer. So it's hard to sometimes explain that, it's going to maybe reduce the risk of cancer. But as anybody who's taken these medications, they're not just water pill, they give side effects. Go ahead.
What's thoracic RT scan?
Oh, I'm sorry. That's a thoracic radiation treatment for these are the women who had lymphoma and got mental radiation, which is neck, armpit, and central chest. These are the women who have high risk of breast cancer because these women end up having radiation at a young age, teenage, early 20s. So they have about 10 to 20 years later, they actually get breast cancer. And they do that mostly for lymphoma.
Had a few people who that's the case.
Mm-hmm. And these women actually don't have an option for lumpectomy because they can't have radiation again. Right. So they have to have the entire breast. Okay, so diagnosis and workup. I mean, we know for anybody who's been through breast cancer diagnosis, we know we try to use minimally invasive biopsy methods, is core needle biopsy, fine needle aspirations. These are the ways we diagnose the breast cancer. There's also skin punch for anybody who has skin changes in their breast. And we identify tumor types, grade, estrogen, progesterone status, HER2 status. So HER2 has been relatively new. I mean, it's been used for more than a decade now, but it's still relatively new compared to the other types. And the staging system in the breast cancer has changed so much since 2018. So before 2018, I'm going to have a slide for that. Let me just try. Okay. So before 2018, we used to have this one card breast cancer staging. I had it printed out and laminated. I would walk around in my pocket. I could stage women in about like 5 seconds. But now that staging table is about 15 pages. There's no way I can put it in my pocket. And never now I'm putting money to laminate those 15 pages. But it's because now, in addition to the tumor type, invasive ductal, invasive lobular, they also have added the grade, the estrogen and progesterone, and the HER2 status as part of the grading. So if somebody goes to a medical oncologist, surgical oncologist, sometimes women tell me they hear different stages. The medical oncologist say you're stage 3 versus I'm telling them you're stage 1 or 2. Sometimes there's a huge discrepancy between 1 and 3. So it's because it depends on which staging system they're using. They're not supposed to use a pre-2018 staging system that's it's outdated. So we only use a post-2018 staging system, which includes all of these factors in staging. So a lot of time I have, heated arguments with my medical oncologist because now my patient is all confused because he told her she has stage 3 and I told her she has stage 1, and it's a huge difference between the two. Come on. So sometimes it gets a little confusing. But these are all the factors that go into staging now because they do affect prognosis. If somebody has a 2 centimeter triple negative breast cancer versus if somebody has a 2 centimeter estrogen positive breast cancer, we're not looking at same treatments. We're not looking at same prognosis. We're not looking at what women have to worry about 10 years, 5 years, 20 years down the road. So to lump them all together as the same stage just didn't make sense. So that's why they came up with this different staging system to reflect the prognosis that 2 centimeter cancer that is hormone positive is stage 1. And that same 2 centimeter cancer that's triple negative is stage 2B. So there's a huge difference based on that because it shows people what kind of prognosis you're looking at based on just these receptor sites. So that was a big change that came out in 2018 that mostly people have caught on. So in terms of diagnosis and workup, we are using MRIs and more liberally these days because MRIs are becoming more sophisticated and the radiologists are getting better at reading them. So we are able to identify small tumors, which may have been forgotten in the past because they just didn't look impressive enough. But now they're getting picked up as smaller and smaller, and we go make sure that we have our margins are clean based on those imaging results. So we do a lot more MRIs, and they're especially important in women with these problems. If they have extremely dense breasts, if we have problems telling the extent of the disease. And every single chemo patient who gets chemotherapy will get a breast MRI. Go ahead.
I have a question.
Go ahead.
I was known to have bad breasts and I was never offered an MRI to get cancer.
Okay.
And I just do you think that would be a trend that they would offer MRIs?
So these are patients with diagnosis of cancer and dense breast. So dense breast automatically does not qualify women for MRI and tends to overread. We do a lot more biopsies in those women. That's been shown that usually comes back benign. So we have been adding ultrasound instead of MRI because again, MRI, even though it's not radiation, we are giving gadolinium dyes, which we don't have enough data on as to what the long-term consequences are. So I do MRIs in a lot of my patients for after cancer treatment and everything is done and they don't have breast, and I do MRIs on them. And I tell them, they give this gadolinium dye. We have no data on what long-term side effects are. So I'm gonna tell you right now, I don't know if this dye is still going to be given in 20 years because we just don't know if it's going to cause any problems. As of now, I have no reason to tell you don't take it. In 10 years, I may something different. But
Another non-invasive it's not very popular is the thermography. I don't know if you do.
yeah, I have seen it. I don't do it. So what the thermography does, it basically looks at the heat patterns in your breast. And I have a lot of patients who don't want to have mammograms and they want to have thermography instead because of lower risk of radiation. And I totally understand that. The problem is I can't act on thermography. If I have a positive finding on thermography, I don't know what to do with it because there is not correlated with what the risk of breast cancer is and what is positive in thermography. For example, if a mammogram is positive / says something is risky, based on the BI-RADS, I'm sure you've done the BI-RADS 1 through 6, what it means in terms of having a 4 versus a 0 versus a 6. So BI-RADS assigns what the risk of having a breast cancer in that region is. So if it's a BI-RADS 1, the risk is as 0 as it gets versus the risk if BI-RADS is 5, the risk is as close to 100 as it gets. So thermography does not tell me that number. I have no way to act on it. If somebody comes to me with a positive thermography, I'm sending them for mammograms because I don't know what to do with that result because I cannot identify a lesion based on a thermography. And it's not been correlated with women's in terms of their menstrual cycle because a lot of premenopausal women do that. And the breast temperature changes based on your menstrual cycle. So sometimes there's a lot of confounding factors, as we call them, with the thermography. Again, it's not medically correlated for us to act on it. So in the future, if they are correlated and there are ways for us to biopsy or evaluate the lesion from the positive thermography to a medically acceptable or doable system, then certainly, I'm going to talk about a couple of newer systems that are coming up. So So that's the MRI, and then we do PET scan or the CT chest abdomen pelvis with bone scan in women who have either locally advanced breast cancer or inflammatory breast cancer. And medical oncologists, they love the PET scans. So they get those annual PET scans. I don't. I would get annual MRI, but the PET scan looks at you from head to toe, and it tells you if there's anything going on in there that's of concern. I usually don't need them after I'm finished with treatment, but the medical oncologists love getting them.
Can you, Dr. Tambar?
Yes.
Can you elaborate on locally advanced disease?
Sure. So the locally advanced disease is a disease that has gone from the breast into the lymph node. So it's not just located in the breast, but it has gone beyond the breast. But it's still only in the lymph node. It has not gone beyond lymph nodes into the lungs or the livers or the bones or anywhere else. So it is curable. So any disease that is locally advanced is curable, and we treat them with curative intent. So these are the women we are blasting with chemos and surgery, which is more aggressive, and everything else that's more aggressive.
I don't know what inflammatory.
Okay, so inflammatory breast cancer is a type of breast cancer which just presents differently. It's not that common, thankfully. I've seen about 4 or 5 of them in the last 5 years. They are basically, it looks like the skin is infected. It's like you have a breast infection. These women come to me after their 6th course of antibiotics in the last 4 months because this infection is just not going away. Their GYN treated them. They saw like another primary who's treating them. It's just not going better. So these women come to me, and if there's truly that, the skin looks like an orange peel. So think of like an orange, like that rugged, thick skin with like pits where the hair follicles would be. It literally looks like an orange, but it's had a French term to its purely orange, which just means orange peel. So the breast looks like an orange peel, looks like it's infected. And these women have tumor cancer cells within their skin. And that what causes things to not drain well and causes fluid to build up in their skin. So if you Google inflammatory breast cancer, you'll see all that. But it basically looks like an orange peel. So these are the women who have no benefit of any de-escalation of surgery, because these women have the worst prognosis, despite the aggressive treatment we do, which is chemo first. Then we do modified radical mastectomy, which is remove the entire breast, remove all the lymph nodes, and then we do radiation on them. They still have prognosis of 40% in 5 years, as in 60% of them will die in the next 5 years, despite that treatment. So those women do not get the benefit of the de-escalation of surgery that I'm going to talk about. These women get everything in the kitchen sink and then some, because despite those aggressive treatment, their prognosis is still not great.
Can you, real quick before you move on too, can you speak to then, so the locally advanced disease spreads to the lymph nodes? Because I get asked this a lot with clients is, women they're like, well, why aren't they doing scans? Why aren't they doing imaging like afterwards? Why aren't they doing a PET scan or a CT or these different things kind of as ongoing routine? If they didn't have that. And so is my understanding is that because unless it has spread to the lymph nodes or they believe that there's a higher chance of recurrence, that it's offset like by the chance of finding some sort of other finding, or like it's just not necessary. Because some people are like, oh, why aren't they scanning me? I want them to look inside my body, right?
Sure.
But they had a stage 1, estrogen positive, and they had chemo, and they had a mastectomy, and now there's no more imaging, and so they get kind of nervous.
Sure.
Can you speak to?
Sure. So for the imaging, when I do I would say there's not a whole lot of standard when it comes to surveillance after treatment of breast cancer is complete and the women are cured. Or the cancer is in remission, however you want to put it. But so what I like to do with my cancer patients, I kind of divide them up in high risk and low risk group. So for my women who are high risk, and these are the women who have triple negative cancer at any age, these are women who have breast cancer before the age of 50, large tumor, growing in the skin, growing in the lymph nodes. These are the women that I do MRIs every single year. And then women who have small estrogen positive, not aggressive cancer after the age of 65, I tend to offer them a breast MRI. Like, if you want, we can do an MRI every year. And then my patient over the age of 75 who have like this small little cancer that we took care of, I tend to not put them through the MRI every year. So, but that's my practice. There's because there's really no standard. There are many people who are like, yeah, just go back to your GYN and they'll continue to do your mammogram once a year and that's all they get. And there's nothing wrong or right about it. I personally identified 3 cancers that were not found because nobody did an MRI. And these are young women who had, I had one woman, she had triple negative breast cancer, had bilateral mastectomy, never got a mammogram again because she didn't have breast. And she changed her doctors because she changed her insurances. So I saw her, this is back in California. And first time she came, she was like 8 years out from her treatment. I'm like, okay, so I mean, things are going well. She's like, yeah, no problems, everything going well. I'm like, you know what? I'm just gonna do MRI for you once a year because you had triple negative breast cancer. You don't have breast anymore. No reason to do mammograms on you. First MRI, she had positive lymph node that were deep in her breast that was found, and she got biopsy. It was triple negative breast cancer. It was only in the lymph nodes. It was one lymph node. So we did surgery, we gave her chemo, and she was fine. I have one patient who had DCIS, which is a very much not aggressive cancer. She was diagnosed in her 30s and had double mastectomy, implant reconstruction, same thing. I mean, there's no reason to do mammograms on you anymore. You don't have a breast. So I did first MRI. She had cancer all over her lungs. Oh, that's stage 4. So I just had, and these are again, personal anecdotal stories that will kind of not fly with other people, but I just, the risk to me is low enough where if a woman is willing to do the surveillance, I'm happy to order it. And I have a lot of women who said, I can never go back to the MRI machine again. It's a tube, I'm claustrophobic, and I'm not doing it. And I respect that. But in my mind, I'm offering them the care that I think will be beneficial. And they can choose and say, no, I don't want it, it's too much. So, and that's personal philosophy because there's truly no standard. They do say once a year you need an imaging, but they don't really specify. They, I mean, the experts, they don't really specify what that should be.
Interesting. Okay.
So, what's new in breast cancer? So just a couple of slides on what's new, and these are still in clinical trials, so don't go looking for it. But it's the first one I want to talk about is positron emission mammogram. So these are the mammogram that kind of look like PET scans. So these are like a combination of PET scan and mammogram. So this is what it would look like in terms of a mammogram that looks kind of normal to actually a PET scan where you can see something lighting up. Same with the PET scan, the PEM scan here, where you will see lesions light up as you go down the breast. So up and coming, still looking at the risk of radiation, still looking at the risk of dye, because these are the women that they're planning on doing a screening with. These and these are, again, radioactive dye, then they want to kind of use them selectively and see what the long-term side effect would be if we were to do this to every woman every year. And then there are vaccines. So a lot of people ask me about what
Is a PEM scan, is it just for breast? Or
PEM
is
is
it, would it
breast.
be for any cancer that they're gonna do, like research to do this?
So PEM is breast because PEM stands for the mammogram part of it.
Oh,
But I'm
okay.
sure they may come up with other organs also. But this PET scan, which looks at all of you, they're just focusing a little bit on breast with lesser radiation because they're not scanning head to toe, well, head to knees. So they are, so it's focused just on the breast area with little less radiation, but they still haven't figured out who would be the best candidate. Would it be the patient who have a high risk? Should it be the patient who only have head cancer? Should be women with like certain amount of risk factors? So they haven't figured out a lot of stuff. So that's why it's not available yet. Don't go looking for it. It's not available anywhere. Not even in like big cities, it's nowhere. So vaccines. So these are also under trial. So these are vaccines that they are working on currently to reduce, to prevent breast cancer. But these are very selective patients. This is not meant to cure all women of all breast cancer. So this is focused on women with BRCA mutation. And this is focused on women who may develop a triple negative breast cancer, which is a closer one associated with BRCA mutation. So this is focusing more on a certain type of breast cancer. And fortunately, this is not the most common type of breast cancer we see. This is the more aggressive type. So the most common is the hormone responsive, the estrogen positive. So this vaccination, unfortunately, is not going to work for that type of cancer. But positive side, silver lining would be that it's not an aggressive cancer to begin with. So they're kind of starting with an aggressive cancer and hopefully expand it to other types of breast cancer. So overall, what's new in breast cancer is de-escalation. So we are de-escalating surgery. We kind of talked about, hold steady and mastectomy and how we come down to like a nipple sparing mastectomy, skipping, keep no surgeries altogether on women who don't have cancer on the contralateral side. Chemo, we're not giving chemo to every patient with a lymph node positive disease. We are trying to see which women have the risk of recurrence in the future, and if they would even benefit from those lymph node surgeries. So we're reducing lymphedema risk in women by a long margin, just by reducing that amount of surgery. Because the risk of lymphedema with a sentinel lymph node is about 2% or less, versus with a node dissection, which is removing like 15 plus lymph nodes, is about 20%. And if they get lymph node dissection and radiation, which is most of the women, the risk is about 40%. So it's a very high risk. It used to be about 60%, so I do want to say we have gotten better, but it's still pretty high. Same with radiation. We're not radiating all women anymore. So we don't radiate women with estrogen positive cancer over the age of 72. So if you have a small tumor, estrogen positive, you're over 72, you can just have a lumpectomy and you're done. We have endocrine treatment. So we are actually not limiting endocrine treatment per se, but we are not giving them for 10 years. So there's actually a test that recently came out. It's called Breast Cancer Index, which tells us if a woman will benefit from endocrine treatment for 5 years or should they extend it for 10 years. So there are more and more testing coming out. And if anybody heard about oncotype test, which tells us about women's benefit from getting chemotherapy. It's a tumor, they take a piece of your tumor and run tests on it to tell us if you will have any benefit of taking chemo. So we're not automatically putting everybody through chemo, which we used to in the past. And the other aspect of what's new in breast cancer is getting more personalized care. It's not a one size fits all, whole steady mastectomy for women anymore. I literally have 30-minute discussion with every single one of my breast cancer patients about their treatment options. I offer them anywhere from lumpectomy to oncoplastic reduction, where we get the lumpectomy and the plastic surgery kind of reduces and lifts their breast a little bit, kind of the mastopexy reduction pattern. And we do nipple sparing mastectomy, we do skin sparing mastectomy, we talk about nipple tattooing. Because the idea that that was kind of in the olden days that you're lucky to be alive with the breast cancer, I think that concept is kind of fading away. Women are becoming their own advocates, if not other people advocating for them. And we realize that breast cancer, if you look back in 5 years, it's going to be a bump in the road, hopefully for most people. So more and more people are living with breast cancer that dying from it. And I have had a lot of women who don't want to look at their breast. I saw a woman last month who said she showers with her shirt on because she thinks it's a science experiment down there, because she had implants and she had her stuff and she's just extremely unhappy with it. So women are, and her cancer was like 20 years ago. So women are living longer and longer. We are surviving from breast cancer. We are living with it, and to be subjected to live with an inferior quality of breast is just not reasonable at this point. So we are offering more and more quality care in terms of reconstruction. I personally do oncoplasty, and I don't know if anybody heard oncoplasty, but it's basically if somebody does not want their breast to look the same, nothing better, nothing worse. I do fill up the holes in their breast that I do after the lumpectomy, and I fill up the holes so there's no divots, can't even tell the scar. I place a scar so that it's well hidden, and basically there's no contour differences. Women can't even tell they had anything removed from their breast. But anybody who wants to look better, I will send them to the plastic surgeon and have the oncoplastic reduction done with the lumpectomy, so they basically get a reduction in breast lifted. And then for anybody who wants a mastectomy, we offer everything from nipple sparing to skin sparing. I'm starting to do nerve sparing so that their nipple sensation will be preserved also. So there's so much up and coming. We are getting more and more women candidates for nipple sparing mastectomy. So, I mean, it used to be that, oh, you have to be a B cup. That is the only woman who can get a nipple sparing mastectomy. Now we reduce the women first and then do a nipple sparing mastectomy for a new planet. So it's come a long way. I believe women still need to be their own advocates and ask and demand for some treatments, because sometimes, again, the idea that people try to profess is, oh, you'll be lucky to be alive in 5 years. And that concept is fading away. I have a lot more women telling me that they feel like a monster. When they look at the mirror, they don't want to look at the mirror. And I just don't want anybody going out there who's my patient and telling me that I mutilate with them. So, and I'm not the one who looks at the mirror every day for them, it's them. So I want them to be happy in their skin. So if that's lumpectomy, or if it's mastectomy, or is it nipple-sparing mastectomy, or it's going flat chest, it's their decision, it's not mine. So they have all the options and they pick what they want to do. And that's the personalized part of the breast cancer treatment, where everything from surgery to not so much radiation, because radiation is hard to change, but definitely surgery and chemo, women can, it's more and more personalized to their type of cancer, to what would benefit them. Not everybody gets the same concoction of medication. Is very much personalized to what the type of cancer is and what the need of the woman is. So with that, I think that's my last slide. So if you have any questions, I'm happy to take. Yes, okay, back there.
I have a question. So when I first breast cancer was like 1999, so it was like pretty old school. And they did some genetic testing, and it was I didn't have one.
Sure.
That's things that so
Yeah, in 1999, they were only testing for BRCA1 and BRCA2. The 36 gene panel has come up in the last 12 years.
So then my next one, and these are all stage 0-1.
Sure.
Was in 2013, and then my sister got breast cancer. Now we had never been able to identify anything, any gene mutation that put anybody at risk. Should we go for more genetic testing, not even for us, but for our nieces?
Did you only have the BRCA1 and 2, or did you get the updated 36 gene panel?
I know another updated one, and I don't remember.
Sure.
It's just, she said, it's everything that's negative.
That's good. Okay.
And then I said, oh, that's good. And she said, eh. I started, and I said, why did you say? She said, well, and it's obviously something's going on with me.
Yeah.
Just.
Correct. So that was, so there are two things. First is to make sure you get tested for the 36 gene panel, because it has been started in the last 12 years. And the second is exactly what your surgeon said, is that we are finding, we're identifying more and more of these new genes, and the gene, clearly there's something going on. I mean, you and your sister, you both cannot be unlucky in the same sense for getting a breast cancer. So there's definitely something going on, and they just don't know what gene that is. I see 5 generations of cancer of all different types in every single member, and genetic testing comes back negative. Clearly there's something going on. They just don't know what gene. And I'm sure, and they're coming up with new genes every so often. So they actually keep your data, they keep your blood, and if new gene has been identified, the company are actually required to test you and update you if any mutation has been identified on their part.
And would that be covered by our insurance?
That is correct. That is correct. It is.
Pretty expensive for that.
I mean, even my patients who do not qualify, but insist on genetic testing, it's about $200. It's not cheap, it's not exorbitant amount either. So most of my patients are willing to spend $200-ish. Insurance usually covers at least a part of it. Most of them cover entirely, 100%. You may have a copay, but for the most part, they are covered, maybe $20 copay, but again, the patient who don't qualify, but having a family history or other reasons, anxiety, anything to do with that, and want the genetic testing, it's about a $200 test. Again, not exorbitant, but not cheap either. And then we had a question there. Yes.
With the post 2018 guideline for
Staging, yes.
Should people diagnosed before that find out what stage they are, what are according to that, or when the oncologist look at the old data and tell you what that?
Yeah, so if you were to go to visit, they should be updating your stage. Yes.
Yes, I have a couple. One, you mentioned flat closure. So if I understand, aesthetic flat closure is now considered like an actual form of call it reconstruction, but, like covered by insurance and all of that,
Correct,
correct?
correct.
When do you typically do aesthetic plaque closure, or do you bring in a plastic surgeon for that?
So it depends on the amount of excision that's required. If
Okay.
you, as I said, if women want to look the same,
Yeah,
then I will not get the plastic surgeon in. But if they want to look better, then
Okay.
I would get the plastic surgeon in.
okay,
So, for example, I will mention she's a small breast, maybe a generous A, maybe a B minus, we'll see. But she has a small little cancer, and I offered her, not a reduction, but more like a mastopexy, which is lifting the breast, because it's really, she cannot move anymore. So, so I offered her a little mastopexy. So what we'll do is, I'll do the lumpectomy, and my plastic surgeon will mostly remove the skin, but kind of bring the nipple a little bit up. So there's kind of like a little curviness to her breast, and then we'll do radiation later. So she wanted to look better.
right,
So it really, my discussion with my patients are, what's your goal? What do you want to achieve at the end of that? Because I can offer you a lot of things, but not everybody wants a nipple sparing mastectomy. Not everybody can have a nipple sparing mastectomy. So 30 minutes of my talk is just talking about what do you want.
and
What are
that's
your
true for
goals?
plaque closure too.
That is true for all, yeah, for
All.
oncoplastic reductions, for lumpectomies, because I go over oncoplasty with them, I
Right.
go over everything.
Okay, thank you. And then I have another question. We were talking about imaging. I keep hearing about this, they're advertising, there's a practice downtown called Integrated Wellness. I believe they do chiropractic, they do nutrition, they do a bunch of stuff, but they are offering something called automated whole breast ultrasound.
Yes.
And it has some sort of fancy, sonosine. And yeah, is that something that you're familiar with? And
Yeah.
is it legit?
Yes, so what they're trying to, the difference between ultrasound and all the other imaging modality
Yeah.
is ultrasound is operator dependent. If your ultrasound operator did not put a probe in one part of the breast, that breast did not get, that part of the breast did not get evaluated. Versus, MRI, your whole body's getting in there. So there's no way a technician, if he didn't push a button, it's a part of your breast, your whole breast is getting tested. Ultrasound is operator dependent. So if the operator didn't put a probe in one part of the breast, they have no information about that part. And that part can have cancer next year, who knows? So they're trying to take that operator dependence out of the picture.
Okay,
So what they do is they put all of you in a machine, and they kind of do, a machine does your ultrasound as opposed to a person.
okay, that's kind of how I understood it.
Yes.
It's
So they,
just-
they kind of take the human factor out of the error.
Right, okay, all right, so could that be a potential, I mean, I'm guessing you typically, clinics like this are often out of pocket. This might not be an imaging thing that's covered by insurance yet, if it's not
Most
kind of
likely
standard of
not.
care.
If it's more expensive, if
Right.
you're charging more for it than
Right.
your usual ultrasound, I think it will take time for insurances to catch up.
Right, but would it be for someone, say, who, maybe had dense breasts, wanted something, maybe thermography, could it be another viable tool for
Absolutely.
monitoring?
Yeah, because for all
Okay.
of my extremely dense patient, I send them for ultrasound anyway.
Right.
So
sure.
if they wanna, again, depends on, resources, how much women are willing to pay.
Okay.
But if they wanna have an automated ultrasound, I would send them to that place. But, depends on the cost, really, if they're asking for like, $1,000 versus 20.
Yeah.
So, we can say, because ultrasound, copay is about $20-ish for most people.
Okay. And then, does anyone else, I have another question that was
Well, you
sent
can
in.
go off.
Okay, you sure?
Yeah.
All right, and I think then that's all of mine. This was sent in from a client who couldn't attend tonight. And I don't know if it's too individual, but we'll see what we can do. My question is, I know there are specific factors that are involved when prescribing tamoxifen, parentheses 20 milligrams daily.
Sure.
But how necessary is it to take for stage 1 ductal carcinoma, ER/PR positive, HER2 negative,
Sure.
with no lymph node involvement after mastectomy and 4 rounds of preventative chemo?
Sure.
Is it prescribed based on age and the ONCA score, and what determines how long one should take it?
Sure.
Age and tumor grade? I've heard conflicting answers, and the study used on the prescription sheet
Mhm.
is only based out of 1,000 women for a 1.7% reduction rate.
Yeah, so, so taking the tamoxifen is based out of a large they've had like 3 large multi-country international studies. They actually profess about a 40% reduction in breast cancer recurrence, as in 40% reduction in risk of cancer coming back. but it does not affect prognosis, as in you're not gonna die from it. It will reduce the risk of cancer coming back, but if the cancer were to come back, you can have treatment for it and you can go live your life like you were meant to live. So it seems very crude to most people that, you know, yeah, you have another cancer, come, I'll take your breast up and then you'll be just fine. You're not gonna
Right.
die.
Right.
But I mean, death is not the only problem here.
Right.
You know, there's other problems that women don't want to deal with, which is having a second cancer.
Right.
So tamoxifen certainly has reduced the risk of recurrences in women with those estrogen positive cancer. We actually use it very liberally. Tamoxifen, not tamoxifen per se, but endocrine. I'm talking
Yeah.
about like general endocrine treatment because I
Yeah.
think the question extends to the same type.
Sure.
So the general endocrine treatment, we actually use it a lot in women, especially during pandemic, when we couldn't do surgeries on women because the hospital was shut down and we were trying to not bring my 82-year-old patient to the hospital to take a little cancer out and expose them to COVID. So during pandemic, we actually shifted to using what we call neoadjuvant endocrine treatment, where while women are waiting for this pandemic to settle down, we've started them on tamoxifens and on anastrozole and other medication to kind of keep their cancer at bay while we didn't know when the hospital was going to open up for the elective surgeries again. So, and we noticed that this pill is actually shrinking tumor. So I had a patient, I saw her in February, fungating breast mass, bleeding. I mean, I tried to biopsy her and she was squirting blood from my needle hole. It was bad. And she was 88 and she didn't want to do anything about it. I sent her to the medical oncologist and he gave her the pill. I just saw her yesterday. Tumor's still there, it's not gone, but there's a little scab. Most of the cancer is gone. I would say it's down to about 30% of what it used to be. So these are the data that
Just
tell
from Tamox.
just from
Oh,
anastrozole.
anastrozole, sorry.
Endocrine
Yeah.
treatment.
Yeah.
Just from endocrine treatment, these cancers are shrinking away in front of our eyes. So I cannot tell you that it's useless.
Okay.
I mean, I saw another patient yesterday. She was diagnosed with cancer in 15, ignored it, came back as a nipple is like bleeding right now, and she's wheelchair bound, you know, doesn't want to do anything. I'm gonna start her on anastrozole.
Okay.
And see her in a year.
Okay.
So it works, you know, it's been shown to work. I don't have any conflicting data. And again, it's not a magic pill, it's not a golden bullet, it's gonna have side effects. So I'm not gonna try and paint a rosy picture either, but it works. So I'm not gonna tell anybody with a straight face that these medications are useless. I mean, they may not have benefited women who maybe have had double mastectomy, 99% of their breast is gone, and they have a lot of side effects from taking it. Sure. But those are selective. Sure, yes.
Okay, mine is about really follow-up, okay, I had third stage, very aggressive. 3 months of chemo, double mastectomy, 12 lymph nodes, gone from my left side, 3 from my right. Radiation for 37 days. And then after that, then they put me on, it was tamoxifen first, I didn't do well, anastrozole, and now exemestane.
Sure.
That's what I'm on now, okay?
Yes.
Been on it for over 5 years already, okay? So now I don't know what to do and going forward. Should I get some scans? Should I get, I do get blood work.
Good.
And everything is okay. Some doctors say it's not necessary to do any more scans ever. I feel better doing them, but I don't know if there's more side effects if you get like PET scans once a year. I feel comfortable with. They say you don't have to. What would you recommend?
So for women, I mean, with the stage 3 cancer, I don't know if you had triple negative or HER2 positive, but usually if it's aggressive enough that you had to take chemo and radiation and mastectomy for it, I would say it was pretty aggressive. I tend to do once a year MRI. Again, as I said, I don't really do a lot of PET scans. That's more of a medical oncology thing.
Okay.
Because PET scan again looks at everything, and if something shows up in your kidneys, I don't know what to do with it. So I will not order a study if I don't know what to do with the finding.
Now,
So that's why I order
do they
MRIs.
have like radiation in either of those?
Sure, so MRI is magnetic, so it actually does not have radiation. It does involve a dye, the gadolinium dye, and as I was kind of talking in the
Yeah,
middle
but
of
you
my
don't
talk,
have-
we don't have a long-term data
Mhm.
on what the long-term side effects of it are. So I tell all my patients, as of today, there's no reason for me to not prescribe it to you. 20 years, we might be looking down on it. I don't know.
I was told from a very good oncologist that works with you. that, it helped my mom too, for a lot of years. That it would probably come back within 5 years. It was that aggressive. I mean, I'm going on 6 years sober, so. I'm hoping to retire, hopefully, and enjoy some of my life, but I just basically wanted to know from you, because I'm insisting on scans. And I don't know if, that's more damaging or if I should just do blood work.
Yeah, there is no real good blood work, I would say. I know they look at tumor markers on the blood. They are better established for pancreatic cancer than colon cancer than ovarian cancer. They're working on a blood marker for breast cancer, the 15.1 or 15.3 or something. It's not been shown to be as accurate. So again, the medical oncologists love the blood tests, they love the PET scans. I just don't know.
Okay.
Because again, I would know if something showed up on the blood, what to do with it. So if I don't know what to do with the test, I don't know it.
And did you hear anything about that semestine, like how many years you could possibly be on it? I hear 5 years. 10
Sure.
years.
So that was that new breast cancer index study that came out that's talking about what's the benefit, if you have a benefit of taking it for 10 years versus you should stop after 5 years. It's not as widely accepted. So it's more about the medical oncologists look at what kind of tumor you had. If they said your cancer's going to come back in 5 years, they'd probably keep you on it for 10.
Okay.
So.
And the last question, between the tamoxifen, anastrole, I guess that's what it's called, anastrole, and exemestane, is one really better as far as results?
I would say all the anastrozole, exemestane are better than tamoxifen.
Okay,
But we cannot give those medications to premenopausal women because for premenopausal women, they're fertility drugs.
okay,
So their ovaries will go into overdrive.
okay,
So premenopausal women can only take tamoxifen. But we wish we could give those women those other medications. In fact, I had a young patient who needed to take anastrozole, but she was 36 and still had her ovaries and were functioning. So her option were to either take an injection every month to kind of kill off her ovaries for the next 10, 15 years. She chose to just have her ovaries removed so she can take the anastrozole.
okay.
Because we just cannot give premenopausal women the anastrozole or the exemestane or the letrozole or any of those zoles.
Okay,
So we have to give them tamoxifen.
okay,
So it's just a mechanism of disease and we just can't give them certain medication because I took letrozole for fertility. So
yeah, I have 3 daughters now, they're going for those scans, late 30s, beginning of 40s.
Yeah.
I mean, everybody in our family has basically passed from breast cancer, grandmother, grandfather, everything.
sure.
So, but the one I have, they did the genetic testing.
Sure.
It did not come from my mom and I cannot pass it. It stays with me.
Oh, okay.
So
it's
I
like
feel
you're-
better about that, I can't pass.
You're-
to my kids. Well, thank you very much.
Okay.
Thanks to my question.
Any other questions?
Do we have any final? I just want to be mindful of time. Does
Anybody
anyone
else?
else?
Yeah, nobody, there's some Q and A.
Okay, any other final questions before we wrap up? All right, well, this was so great. Thank you, Dr. Tambar. Whether for ourselves or someone we know, are you taking new patients if needed?
Yes, I am.
Okay, and yeah, thank you again so
for having
much.
me.
This was really helpful. And everyone, we do typically have, wait, let me stop before I move on to that. We've already taken care of next week with the lymphedema workshop or seminar that's going to be here. Our next monthly meeting for our next education series is December, do you know the date? It's the second Tuesday in December, whatever it is. It's the second Tuesday in December. And for those of you who got to attend our Day of Renewal workshop in October and met Erica Hawley of Evolve with Erica, she talked about healing your relationship with food, kind of talking about a framework on how to use values to be in relationship with food in your body. She's actually going to be our featured speaker that night. So she'll be doing a little bit more comprehensive extended talk of what she shared with us at the Day of Renewal. So that'll be December. I know in the past there's sometimes been kind of like a member holiday party. Sorry, what, Claire? 13th. Thank you, December 13th. But instead this year, we're gonna go ahead and just and utilize that night for another speaker. And if anyone wants to stay Judy, are you,
I'm available if anybody wants.
if anybody would,
Support group.
yeah, if anybody would like to stay for a little community or talk, Judy is here to lead that. And always please remember that, you know, we're here for you. If you have questions, ideas, recommendations, we are actively working on a lot of things behind the scenes to make sure that we are reaching and serving everyone in the community. And we'd love to hear from you. Is there anything else you can think of, Rob? All right, Rob Jones, everyone, our executive director. Always thank you to our wonderful, wonderful. Thank you to our wonderful